I'm Beverly Chester, and I'm here to talk about incorporating patient-provider messaging in the clinical setting as an evidence-based practice. Patient-provider messaging is a basic service of patient portal software. A lot of times the patient portal will also include other services like appointment scheduling, prescription management, labs and health records and billing info, maybe more. It depends on the package that the clinic purchases. But for the case of this project, we're going to look at just patient-provider messaging. Specifically, we are looking at asynchronous communication between the patient and provider. Synchronous is when both parties are present. So that could be an in-person office visit, a telephone conversation, or even a live chat. We are talking about asynchronous. So both parties communicate at different times. So that might be an example of, say, email. And usually within a patient portal, they will have their own type of email services where a message can be left in the portal. Therefore, it's accessible only by the provider and by the client versus email. Somebody can, open your email at any time, but a patient portal will log you out on your own, providing an extra safety precaution there. We're going to discuss benefits to the clinical setting. So those would include patient benefits, provider benefits, staff, and the overall cost-saving business benefits. And we're going to discuss barriers to their meaningful use. Then finally, we will discuss implementation of our evidence-based project, cost-benefit considerations, and the evaluation. Benefits to the patient include fewer unnecessary office visits because a lot of times office visits for follow-up questions are just for simple questions that can be asked over this asynchronous communication tool. So if we can ask simple questions over this tool, then it saves time and money for the patient. There will be fewer phone calls. A lot of times patient satisfaction rates are how quickly a phone call is fielded to them. So it prevents them from having to sit over long hold times waiting for someone to answer the call. And giving access to the electronic health records and other self-efficacy tools benefits the patient by improving their disease management and improving their education of their different conditions. Benefits to the physician are also tied to the answering of simple health questions. So when you have fewer patients coming in for unnecessary office visits, you can then open up more appointment slots to new patients. That improves their productivity, the physician's productivity. And so they can field questions at the end of the day using this portal communication tool. And so that's kind of just adding the ability to answer questions while seeing new patients, and potentially leads to higher satisfaction ratings as more patients are having their questions answered and able to see their health benefits improve with their self-efficacy of disease management. Clinic staff will be fielding fewer phone calls as fewer people are calling in and waiting on hold for longer times. And a lot of times these basic package settings include self-scheduling tools, which is just another additive bonus, a perk to having a patient portal is that clients can schedule their own appointments, reschedule, cancel, things of that nature. So again, just less tedium for clinic staff, and they can put that energy towards other tasks. Overall cost saving advantages to the business as a whole is the potential to save about $90 per patient after the first 3 years of portal use. It could increase revenue as more physicians have higher productivity, higher billing rates, and can see more new patients. Therefore, we can bill more productive hours. And with patient education and self-efficacy tools being embedded in the patient portal, that's just another way that we can reallocate nurse and staff time to do other tasks, thus improving the overall productivity of the business as a whole. Barriers to patient use include computer and internet access in the home, basic computer skills or comfort with computers, special needs users. So that could be special needs at any age, any demographic, but especially within the older population. We'll get into this research in a little bit. User experience, especially the first impression of the patient portal, matters and is a barrier to continued use. The ability to conduct enrollment or patient registration. Again, we'll get into the research with all of this in later slides. Barriers within the clinical setting is the ability to pay for the initial upfront cost of, uh, of adopting the new patient portal, and vendor training, so being able to pay for staff training for however long the vendor training requires it to be, a couple days or a week or whatever. It may be necessary to close down the clinic for this vendor training, which would again be wrapped up in the whole cost of how much does the portal cost, plus how much does it cost us in not seeing patients for a day or a week while we're conducting this training. Staff will need to be trained on both user ends. So on the staff end, how do we put the self-efficacy tools on the portal, and how do we conduct patient education, and how do we do the portal messaging services? Plus, certain staff will need to be trained in how it's done on the patient end so they can better educate patients and help make continued use more viable, by being able to field questions over the phone and how to access the patient portal, how to log in, things of that nature from the patient end. There will need to be promotion of services actively, including possible on-site patient training, on-site patient enrollment, and that will require staff to be able to conduct those things. So all of this is wrapped up in a bigger, higher cost. There might be a need for more staff to help conduct these on-site opportunities. Our literature review begins with patient portal usage and patient satisfaction scores. In this 2022 study by Fareed McEwen, Vink et al., researchers found correlations between patient portal usage in the inpatient and outpatient settings, and found corresponding patient satisfaction survey ratings to their patient portal usage. What they found were there were activated portals in over half of the outpatient population, and a little less than half, 46% of the inpatient population. So that seems to suggest that this is a popular tool, and it is perceived as beneficial to much of the outpatient population, but we do have opportunities for growth. Demographics of this population were most often white, over 65 years old, and had commercial insurance, which is correlated to a higher socioeconomic status. Survey scores for doctor communication, nurse communication, care transition, and discharge were generally higher as compared to those patients without activated portals. Biases and confounding factors do exist with this data. For example, survey scores may be confounding, as in an indicator of racial biases or socioeconomic biases of how clinicians communicate and care for patients at who are more often white or at a certain socioeconomic status. Our next study is barriers to patient portal access and usage. In this 2020 study by Turner, Clary, Hong et al., researchers utilized the Health Information National Trends Survey, which is the acronym HINTS, to identify barriers to adopting patient portals. The non-user demographics were most often unmarried, uninsured, Black or having Hispanic ethnicity, having less than a college degree, with lower income, lower socioeconomic status, and most often lived in rural areas. Researchers identified the importance of having a simple, intuitive user interface and user-centered design for visual needs or language needs. User experience was determined incredibly important and vital to the continued use of a portal. User design, having control over the language, especially for, Hispanic ethnicity, having control over colors and text size for older clients, and for people with certain visual impairments or other physical needs. On-site registration and enrollment was found to be helpful for people who had lower socioeconomic status, maybe didn't have access to computers and internet at home, or having lower education attainment might suggest being less comfortable around computers. So having the enrollment on site was helpful for this demographic. Lack of comfort using computers or no access to computers and internet could be mitigated with in-person portal activation and access to toll-free technical assistance telephone hotlines. Our next study is pediatric patient portal usage. In this 2019 study by Jalagi, Valderrama, Vangala et al., usage of patient portals in pediatric settings, either by proxy, meaning an adult, or the adolescent themselves. Researchers found activated portals were utilized in the previous 12 months by 64% of the study population, which is a good indicator that this is a popular tool and perceived as beneficial. Demographics were most often white, young, being in a pediatric setting, having commercial insurance, and with English-speaking families. The study noted that 4% of adolescents used the portal on their own by age 12, and that grew to a whopping 60% by age 15, and even higher to 75% by age 17 using the portal on their own, which again suggests this is a very beneficial tool and desired among this cohort. Biases also exist with this data. There's potential for racially based or socioeconomically based confounding factors. Our final study is user experiences in older adults. In this 2019 study by Ports, Bayless, Bull et al., they discovered, or they utilized the technology acceptance model, which guided questions given to focus groups to identify user intent, user behaviors, perceived usefulness, and perceived ease of use of a patient portal. Demographics of the focus group participants were most often white, female, older with a mean age of 78 years, who regularly used email, internet browsers, and other simple computer technologies. Researchers split the participants into 6 focus groups. 3 were of portal users who already used their patient portal, and 3 were of non-users. Patient portal users identified the most popular feature being the messaging services, the asynchronous patient-provider messaging. Non-users identified barriers to why they hadn't activated their patient portals. So many desired in-person communication, which provides the opportunity for clinics to promote this tool as assisting or complementing, supplementing patient provider communication rather than being used instead of in-person communication. Some clients did not know the patient portal features, which provides clinicians the opportunity to promote these features in office. And many non-users simply didn't think they needed it. So having the enrollment on site could help staff train these non-users and show them how the patient provider messaging works, which is the most popular feature, and just basically giving them a little training so that they can see what the aspects of the patient portal are, and they can discover how they can use it and need it in their own life. Both groups, the users and non-users, identified negative components of the user experience, which were the visual aspects and not having control over the colors and text size, just for improving the visual construct of the website and being able to use it better, because again, this is an older population with more visual impairments. For the purposes of our project, our study design is quasi-experimental with mixed methods. So interested patients and providers can enroll. There will be no randomization, no control group. We will collect both qualitative and quantitative data. Qualitative data will be a survey given at enrollment and again at the 6-month follow-up. That survey will be the system usability scale developed in 1986 by John Brooke. Quantitative data will be actual portal usage measured at the 6-month follow-up. We have delineated quarterly goals for this project, and the first quarter goals are to engage and train the staff and providers on the patient portal. Research suggests starting early with clinical staff buy-in, help them improve their own comfort with the portal and its uses, educate them on the business boosting aspects and how this is going to complement their services, reduce their real-time job tasks, and improve their ability to serve more clients, thus improving the revenue of the business overall. Then, after we have clinical buy-in, we can engage patients and collect the interested participants, being interested patients and providers. Our third quarter goals include initiating patient registration for the pilot testing and beginning to collect the initial survey data. Our fourth and fifth quarter goals are to monitor the provider and patient experiences, maintaining the promotion for enrollment and maintaining the staff buy-in, basically just keeping everybody interested in utilizing the portal. Our sixth quarter, final quarter goals are to begin the final pilot test survey using the system usability scale for the 6-month follow-up, and beginning the data collection process for the actual usage measures. Then we will analyze that data and provide it to the clinical supervisor team and go from there on how to introduce this patient portal to a wider scale of patients and providers. The cost-benefit analysis will begin with the costs. Basic software packages can cost anywhere between $100,000 and $140,000, which means smaller clinics might need to have this cost up front, and that could be a bigger burden on some smaller clinics. EHR integration could be $20,000 of that upfront cost, so it does take quite a bit of staff time or vendor training to integrate the EHR into the software packages. Providers should expect to pay $30 to $40 a month for its continued use, so to stay enrolled and to stay active in the portal, it does require a monthly fee. The vendor supplied portal training will be included in package costs, but what is not included in package costs is paid staff training days. So paying your staff to be there for the training, and you have to do your own separate cost benefit analysis on should you close the office for those days and not have revenue for those days, or should you hire support staff to come in for those days to keep the clinic open. Hiring support staff means additional administrative aides and additional nurses, so that could be to keep your clinic open. Also, that could be for the days that we offer on-site enrollment, on-site registration, and you'll need extra staff there for those days to help clients do the enrollment process. Someone will need to physically be there for the patients. Now, the benefits are that there will be improved patient satisfaction ratings, and with improved patient satisfaction, you'll have more repeat customers and more word of mouth client advertising, so better new patient revenue. There will be improved self-efficacy and disease management of the patients who utilize the patient portal, meaning that their health will be better managed and cost the clinic less time and money in seeing those clients in repeat visits. And more efficient communication means that there's higher productivity for the physicians and staff, fewer fielding of phone calls, and fewer unnecessary office visits. Again, there will be fewer unnecessary office visits, saving time and money for both the patient and provider. There will be less time spent fielding phone calls, which will also improve those patient satisfaction ratings. After 3 years, there's an average saving of $171,000 per year after that. So your upfront cost of $140,000 is then basically reimbursed by that time. It's justified by 3 years of patient portal usage. After 3 years, we can safely say there's $90 per patient saved in all of these, better self-efficacy, better disease management, fewer unnecessary office visits, less time on the phone. And so that does justify the upfront costs. Our evaluation will be the survey provided at the beginning and end of the pilot test, which is the system usability scale. We will compare qualitative data to the actual usage quantitative measures. And then for our business processes, we will provide a formative process evaluation, basically asking how well was the project carried out? How can we better support the clinical staff in our next session of patient enrollment, and maybe providing more training in certain technical skills. Asking what did we miss and what could have been better for the staff side of the trainings and staff side of the experience. In conclusion, the important takeaways are that there are differences with age and generation in technological uses and the perceived benefits of patient portals. Remember that about 53% of the older population in the one outpatient study utilized the patient portal versus 75% of the younger group by age 17 utilized the patient portal. So you might have to work differently with providing more training with the older generation. Demographics may be an indicator of access to technology or an indicator of racial bias in the clinical setting. Either way, we need to provide opportunities to close these gaps with access to technology by providing on-site trainings and probably some kind of on-site racial bias training, racial sensitivity trainings. User experience at the first use is critical to the continued use of the patient portal. So having a positive interaction with that first time logging in or enrolling is critical to continued use. Having a simple user interface is better. Less is more. The interface should be intuitive and easy. Again, we're expecting to have a lot of older generation needing better guidance and easier interface to have continued use. Promote the portal from within the clinic. That active promotion is critical to the continued use for clients. Offer enrollment and registration opportunities and portal trainings on site.